Good morning, everybody. Happy New Year. We're going to wait a couple more minutes as attendees trickle in before we get started. While we're waiting for other people to trickle in, I'll just make a couple announcements. As I said before, Happy New Year, everybody. I can't believe it's 2023. I don't know where the last 5 years went. So today, we're really excited to have two speakers. The first speaker will be Alessandro Zulli, who's a PhD student at Yale, who's going to be talking about wastewater surveillance for norovirus, RSV, and influenza A. And then our second speaker will be Janell Routh from CDC to talk to us about the CDC investigation of polio using wastewater in New York. And then I also just want to announce our next set of speakers in February. We are going to have Cara DeLeon from Oklahoma about WBE for bacterial pathogen tracking. And then Otak Conroy Ben from Arizona State talking about her experience working on reservations with WBE. So with that, we're going to go ahead and get started. And I'll ask for Alessandro to share his screen. And as he's sharing his screen, I want to remind you all of the rules for the webinar. So please put your questions in the Q&A. And you have the ability to upvote questions that you think are interesting that you want to be asked during the facilitated Q&A. And Alessandro will speak for 20 minutes. We'll have 10 minutes of Q&A, and then Janell will speak for 20 minutes, and we'll have 10 minutes of Q&A. Okay, Alessandro, thank you.
All right. Thank you for the introduction. Hello, everyone. Thanks for being here. I'm Alessandro Zulli. I'm a graduate student at Yale University Environmental Engineering, and I'll be presenting on the work we've done to expand and give meaning to our wastewater monitoring in New Haven. I'll be focusing—
Alessandro, do you present your mode? Sorry for interrupting you.
Oh, sorry. Is it not in presenter mode?
It's showing the speaker notes as well as the preview of the, now we're seeing if you can switch.
Let me figure this out. Give me 1 second.
Okay, no problem.
Let's do screen 3. Does that work?
Now we're seeing your browser.
All right. Always fun. Is that better?
Yes, that's perfect. Thank you.
Okay. So hi, sorry about that. So as I was saying, I'll be focusing on norovirus, RSV, and influenza A, and how our wastewater monitoring compares to the available clinical data through EPIC, which is an online medical record that's used by Yale New Haven Hospital. Like most, our monitoring started with SARS-CoV-2 and settled solids back in March of 2020. Since then, we've expanded our targets extensively, which is shown on the graph on the right. The graph on the right shows wastewater concentrations normalized to the maximum measured in the time period for a variety of viruses that we're currently looking at. We've also begun working very closely with Yale New Haven Hospital, which is the largest healthcare provider in Connecticut. This gives us unique access to clinical testing data, as the hospital is a research hospital with significant amounts of testing capacity and a good reason to use it. Further, we've been providing our data in real time to the public on our website, as these concentrations are fundamentally a matter of public health. So here's a quick look at what the targets we're currently monitoring are. We have our heavy hitters with COVID-19 and its variants, influenza and RSV, but we've also been able to monitor less acute and less common viruses such as norovirus, monkeypox, and adenovirus. Monkeypox is particularly interesting, as we've been able to detect it even when cases could be measured on one hand in a population of 200,000. So as I mentioned, our heavy hitters were SARS-CoV-2, influenza, and RSV. The reason becomes pretty clear when you start plotting daily case data as measured through EPIC. On the graph on the right, we see that daily cases of SARS-CoV-2 never dropped below 100, RSV has a long tail of 50 to 80 daily cases, and influenza is currently outpacing SARS-CoV-2 cases in New Haven. These viruses are also of particular interest due to the levels of morbidity and mortality that they cause. RSV mainly affects toddlers and infants, which is a particularly vulnerable subsection of the population. Indeed, during the peak of this last RSV outbreak in late November, it rapidly outpaced SARS-CoV-2 in those subpopulations. Influenza, which was once the main respiratory virus which we worried about, has had a quiet couple of years, but we've now measured more cases in the last 2 months than the previous 3 years combined. Now, I called it a triple-demic, and if we're going solely by EPIC case data, that would be accurate. However, I want to point out that there's a fourth epidemic of sorts happening in New Haven, which is so far largely only reflected in wastewater concentrations. Norovirus G1 concentrations have increased 50-fold in just a few weeks and show very little sign of slowing down. So let's take a look at RSV first. Worldwide, it's responsible for somewhere between 66,000 to 199,000 pediatric deaths, and it hospitalizes 2 to 4 million people. While it's less of a concern for mortality in the US, it is a leading cause of hospitalization in infants. In New Haven specifically, we can look at the graphs on the right to determine the severity of this last RSV outbreak. The top graph shows daily cases of RSV from 2020 to 2022. So we see that case rates are 4 times higher in this last outbreak than the last major outbreak last year. The bottom graph zooms in on this most recent outbreak. So there's been a total of 3,097 cases recorded by EPIC, which is more than the sum of 2019 to 2020. During the peak of this epidemic, pediatric cases outnumbered COVID-19 cases by a factor of 2. This was a real public health emergency in New Haven, with several news articles and statements made, because it led to a severe shortage in ICU units for infants and toddlers. Now, let's compare our EPIC case data to our wastewater concentrations. The graph on the right shows our wastewater concentrations in blue, overlaid over the daily case data in red. The two are largely in agreement, with an R-squared of 0.74. We've used this data to build models which predict case rates and RSV hospital admissions with a high degree of accuracy. So the other matter of interest is whether this wastewater signal can serve as an advanced warning signal on RSV. So at a glance, the data suggests that increases in RSV concentrations predate increases in caseload, which is in line with the longer incubation time of RSV at 3 to 8 days. To investigate the potential of RSV as a warning signal, we ran a cross-correlation analysis of our wastewater concentrations to EPIC case data. Our y-axis here represents the correlation coefficient, and our x-axis is wastewater signal, lagged. We first note that the distribution is left skewed, which is a good sign. as it indicates that our wastewater signal is predictive rather than a lagging indicator of cases. Compared to similar analyses for SARS-CoV-2, we note that this distribution is flatter, which could be due to a variety of reasons, including differences in shedding behavior. Our lag of 5 showed the highest correlation, indicating that it's likely the most predictive of cases and positivity, and could indicate up to a 5-day warning time for RSV outbreaks. We then took a look at a fairly simple but potentially powerful analysis. We took the sum of our wastewater concentration and compared it to the sum of our cases. In a way, we're integrating our two epi curves over time. The results are presented here with cases on the x-axis and concentration on the y-axis. This then allows us to perform a very simple linear regression represented by the solid black line, which gives us a slope of 3.62. This slope actually represents the copies of RSV we measured per additional RSV case that we monitored. And this is all in a system with fairly good clinical testing. So using this, we can accurately predict daily cases of RSV at the hospital, and applying the same method to RSV hospitalizations, predict the amount of resources, such as ICU beds and staff, required based solely on our wastewater concentrations. And we've tested this, and it's very accurate 95% of the time. Now, let's talk about another virus, influenza. Before COVID-19, this was the respiratory illness in the United States. Worldwide, it's responsible for hundreds of thousands of deaths and significant amounts of morbidity and economic loss. In the top right graph, we see what influenza has looked like in New Haven for the past 2 years. Thanks to social distancing and mask wearing, there have been very few cases, with 2 minor outbreaks in 2022 prior to this one. The scale of this latest outbreak, however, is immense, with more cases since July than the sum of 2019 to 2022 to that point. In the bottom right graph, we see the almost exponential increase of influenza cases here in late November, reaching almost 400 daily cases and outpacing COVID-19 for a significant period of time. Now we're going to do the same thing, and we're going to look at our wastewater data overlaid on our EPIC data. The orange line here represents our wastewater concentrations, while the blue bars represent daily cases for clarity. The two are actually in great agreement with an R-squared of 0.89. So there's a few things to note here. One is that the most recent outbreak appears to more closely match our wastewater concentrations than the previous one. And the other is that unlike our analysis of RSV, there appears to be little to no lag between the two measurements. They seem to rise almost simultaneously. So here we present the same cross-correlation analysis as our RSV one, looking at our influenza A wastewater concentrations compared to EPIC case data. While this is still a slightly left-skewed distribution, this is much more symmetrical than our RSV and SARS-CoV-2 distributions, and the correlation drops off significantly faster. By the time that you're at a lag of 5, you're already below 0.5 correlation. This is likely due to both differences in shedding and the much shorter incubation time of influenza, which is 1 to 3 days typically. Lag 0 here has our highest correlation coefficient and is likely the most predictive of cases and hospitalizations. We then perform the same cumulative concentration comparison for influenza. Here, though, the linear relationship is not nearly as clean-cut as our analysis of RSV. In fact, the graph on the left shows the analysis for the entire time series, starting in February of 2020 and using all of the data we have about influenza, while the right shows the analysis starting on September of 2022, which is only the most recent outbreak of influenza. The two have significantly different slopes. Now, this is a work in progress, so there's several possible explanations for this, including differences in shedding behavior, vaccinations, but I believe the most likely culprit is differences in testing. So I'm looking for a way to include positivity to control for that. Regardless, separating the model into 2 distinct time periods leads to much more accurate predictions and two distinct slopes, one of 3.3 and another of 1.92. So this same analysis ran here can be applied to hospitalization to predict resource needs as we did with RSV. Now, we see all of this data reflected in our EPIC cases. Let's talk about one that isn't. I mentioned the hidden epidemic of norovirus. We believe that wastewater signals represent a real outbreak, however, and let's do some background on that. There's 3 human noroviruses, G1, G2, and G4. Of these, G1 and G2 are the main drivers of human infections. 85% of norovirus outbreaks are caused by norovirus G2. They're a hidden cause of billions in economic loss through sick days, and clinical tracking is largely non-existent, as the symptoms are manageable at home in most developed countries. In developing countries, diarrhea and gastroenteritis are actually responsible for up to 200,000 deaths yearly. However, norovirus, even within the United States, remains a huge cause of morbidity in nursing homes and schools, and gastrointestinal complications correlated to norovirus infection can be fatal in these older populations. So let's compare our norovirus concentrations to EPIC case data. The blue line represents normalized G1 concentrations, the red line represents G2 concentrations, and the green dots represent weekly, not daily cases. As we can see, there's very few reported cases of norovirus, with 8 being the most reported in a single week since 2019, despite relatively high norovirus wastewater concentrations. This is again due to the fact that these outbreaks are largely localized within a single location, such as a school or a nursing home, and they lead to symptoms that are manageable at home. Notably, norovirus G1 concentrations in wastewater do correlate to cases with an R-squared of 0.55, while norovirus G2 does not. This hints at some differences between the epidemiological behaviors of the two viruses and is something that we're going to talk about a little more. So I wanted to show these differences between norovirus strains. Studies have shown that there's up to a 10% co-infection rate between the two, which is reflected in our wastewater findings, showing a mild correlation between the two signals. However, when we look at the bottom right graph, where concentrations are not normalized, it shows the dramatic difference in behavior between the two viruses. Both viruses were relatively stable and quiet at low concentrations up until September. G2 has shown a sort of seasonal increase starting in September, and it's remaining relatively constant, though it's waxing and waning. G1, though, has shown a much more dramatic increase, with absolute concentrations being 4 times higher than the equivalent G2 peaks, despite the fact that it was somewhere around 10 times lower when it wasn't active. This is reflected in the correlation we found between norovirus G1 and weekly cases, but not G2 and weekly cases. These facts are overall indicative of G1 being associated with acute outbreaks, while G2 represents more seasonal environmental trends. So previous studies corroborate this somewhat, with norovirus G1 outbreaks being almost entirely acute institutional outbreaks rather than sporadic environmental ones. Okay. And then lastly, I'd like to talk about some future work that I'll be using this and similar data for. I would like to work with our collaborators in the health departments to define an outbreak of these viruses, and then apply logistical probability monitoring to our wastewater signal, which would allow us to assign a percentage of an outbreak probability with an inbuilt advance warning due to the lag between wastewater signals and cases. I'd also like to investigate potential competition between these viruses and whether we see those trends reflected in our wastewater data. They peak at different times despite using the same method of transmission, and evidence pointing to synergistic infections such as between COVID-19 and RSV. Lastly, I'll be looking into comparing our results of norovirus, for which we don't have good clinical case data, to non-standard epidemiological signals such as weather patterns. So that said, I'd like to thank my lab group, all of our collaborators at the Yale School of Public Health and Connecticut Department of Public Health. That's a picture that we took. It's the only non-blurry one we took, and I had my eyes closed in it. So thank you for your time, and I'd be glad to take any questions.
Thank you, Alessandro. So just as a reminder, please put your questions in the Q&A box, and you can upvote any questions that you're interested in. So we have plenty of questions. So I'm just going to go through them as quickly as I can. So the first question is, what is the availability criteria for RSV testing in the catchment area?
I'm sorry, could you repeat that?
So availability criteria for RSV testing. I guess it's about how frequently testing is occurring for RSV.
Yes, so I can pull up data on the number of tests that the Yale New Haven Hospital runs, but for RSV, I think it's around 4,000 weekly tests. So a couple hundred tests each day. Okay.
And then, yeah, there were a couple of questions about normalization. It looked like you were normalizing to the maximum,
Yes.
For both the for all of the all of the targets, correct?
Yes.
Okay.
So we know.
And
so
one of the questions.
Okay, go ahead. Sorry, my bad.
One of the questions was about advantages of that compared to PMMOV.
Yeah, so we measure crassphage in all of our wastewater samples as another indicator of normalization. But crassphage actually seems to vary somewhat. PMMOV, I know, is also subject to actually a higher degree of variation than something like crassphage. So we normalize all of our wastewater signals first to total nucleic acids extracted. We found that total nucleic acids extracted have an almost one-to-one correlation with the concentrations that we measure, particularly after doing some spiking experiments and recovery experiments. And then we do the normalization to sort of the maximum we've measured over that time period, just so you can compare the viruses to each other on the same graph. It's not a way that we actually analyze the data. The data is analyzed in its sort of raw adjusted form. But when you're trying to graph all of these on the same graph and trying to look at what the seasonal trends are, when did one go up, when did the other go up, you need to be able to compare these sort of maximums.
And then what were the methods that you used to concentrate viruses for the norovirus and RSV?
So we don't do any type of concentration of these viruses. Our extraction process is automated using a Kingfisher Apex system. We do a sort of modified wastewater protocol that they have where we add phenylchloroform for better recovery. And then after that, we use the undiluted neat samples to run our analysis. Before we moved to ddPCR, when we did QRT-PCR, we used, or RT-qPCR, we used to do dilutions to prevent any type of inhibition. But we haven't seen, through repeated experiments and sort of measuring replicates 10 times, we haven't seen any of these issues with ddPCR. It appears to be very, very consistent.
Okay. And then on your analysis, when you presented correlations between clinical data and wastewater data, one attendee was wondering what the correlation method you used for those R-squared values.
The R-squared is, and it is just a very simple R-squared, actually. For our models, we use an adjusted R-squared, and we do model selection using AIC and BIC, depending on which one is more conservative some of the time. But for first looks at just looking at whether the two signals correlate, we take our raw daily data for cases, our raw daily data for wastewater, and simply do an R-squared.
So like a linear, like a straight linear model. Okay.
Just a straight linear model.
Okay. And then So have you looked at how flow rate, sampling location, so distance, settling time if using solids, which you've already explained, and population served affect your model calculation? Is there a method for applying this to other sites by incorporating these variables?
Yes, so we actually published a paper on this, I want to say like 6 months ago, because we did this monitoring for a solid year and 3 months in 7 different Connecticut locations where the population ranged from sort of 20,000 in a place like New London in the east of Connecticut to 250,000, 300,000 in New Haven and Hartford. And what we found was that you do have to adjust for these things. You have to adjust for population, or you have to adjust for flow rate. The two are sort of perfectly linearly correlated most of the time. Flow rate just depends on what the population served is, but you do have to include that in the model. The easiest way to do that is to sort of build separate models, but you can also build a singular model that adjusts for each one. And that can be either multiplicative or a flat factor, depending on how willing you are to lose some sensitivity.
Okay. Then were there any community interventions with the norovirus or RSV findings? So like outreach to daycares or other types of interventions as a result of this research?
Yeah, so we work directly with sort of the local health authorities, and they put a lot of the local nurseries and daycares on sort of high alert, tried to tell them to leave kids at home if they were sick, because we were running out of ICU beds, as I mentioned here in New Haven. I don't know if it's an ICU. I'm not a doctor, so not an expert on that. For norovirus, we haven't done any type of public health intervention yet. It's not necessarily a public health crisis. It's something we see in sort of school absences increasing, and in nursing homes having higher rates of no-shows from their staff and those similar things.
Cool. So related to kind of the lead lag analysis you did, one of our panelists had a question about whether the EPIC data have any reporting delays. So yeah.
So EPIC data has some reporting delays. It takes time, obviously, for doctors and staff to put it together. But the tests, when we run the analysis, are by date of specimen collection. So while a sample might be collected, for example, on Monday and not processed until Wednesday and not put into the system until Friday, we compare to that Monday data. So when I talk about these lags are actually even greater than shown by this data because it takes time to process, but we do compare to date of specimen collection.
So this was about how your model predicts the needs, like ICU beds and some of those things that you were talking about. One question was with respect to the RSV model, those resource needs, is it, I guess, the pediatric needs versus the non-pediatric hospital needs? So are you able to predict those separately, or is it just a combination of predictions?
Yeah, so thankfully, due to our close working with the Yale New Haven hospital system, they're able to provide case data and testing data by age tranches. So like 0 to 12, 12 to 25, and then 59 to everything. So we're able to account for that in these models, right? I'm able to do the modeling for just the 0 to 12 age. I'm able to do the modeling for just the 59 plus age group, or I can do a sort of combined model looking at overall hospital resources. We're still in the sort of early stages of this, so we're only really using this internally with them. But what we found is that the combined model does a good enough job that you don't really need to separate out the model, because when you start separating out that data, you get into these problems with noise, because the testing is separated and you might have more tests for one than the other on another day. And then you have to account that through positivity.
All right. I think we're probably out of time. There's a few more questions I wasn't able to get to in the Q&A, and then a couple from a panelist I wasn't able to get to, but thank you so much, and I'll pass it over to Janell.
All right, thank you.
All right, everyone. Good morning or good afternoon. Really happy to be here today to talk about the poliovirus response that we have been working on with our New York State colleagues, and definitely presenting here on behalf of everybody who's been involved in the response since July. I wanted to begin quickly with a short background on poliovirus. It is a Norovirus group C in the family Picornaviridae, and it consists of a single-stranded positive RNA genome and a non-enveloped capsid. There are 3 serotypes of poliovirus, and immunity to one serotype does not produce significant immunity to other serotypes. Person-to-person spread is via the fecal-oral route. There is some oral transmission, but definitely doesn't play as big a role in settings with suboptimal hygiene and sanitation. Patients are most infectious immediately before symptom onset, and the virus is shed in the stool for up to 6 weeks with a range of about 4 to 8 weeks, which does make some of that wastewater testing possible for poliovirus. Virus can be shed in people who either have minor symptoms of polio or who are asymptomatic. So paralysis really occurs in less than 1% of all poliovirus infections, and that does vary by type. We really say that one polio case does represent an outbreak, because 25% of people who are infected will have just mild symptoms, and 75% of those infected will actually be asymptomatic, but again, can continue to shed. So I wanted to just talk a little bit about a brief overview of the history of poliovirus in the United States and global eradication efforts to date. To ground everyone in where we stood with poliovirus in the United States, at least until July of this year, here is an epidemic curve with paralytic polio cases on the y-axis and time in years on the x-axis. This spans the year 1950 through to 2020. And you can see here on the graph with the initiation of the inactivated polio vaccine, or IPV, in 1955, followed by oral polio vaccine in the year 1961, cases of paralysis really did fall rapidly in the United States. Poliovirus vaccination is an extremely effective vaccine for the control of paralysis. The last indigenous wild-type case of polio in the United States was in 1979, and the Americas were certified as polio-free in 1994 after that last case in Peru in 1991. To eliminate vaccine-associated paralytic polio, the United States did switch to an all IPV polio vaccination schedule in the year 2000. So from 2000 on, people in the United States only receive inactivated polio vaccine. And that does become important because we know for oral polio vaccine, it provides good gut or mucosal immunity, whereas for IPV, even though it protects against paralysis, you don't get that mucosal immunity, and therefore you can still be infected even though paralysis does not develop. So globally, happily, the incidence of poliovirus has decreased by about 99%. In 1974, the expanded program on immunizations was created to bring vaccines actually to most countries throughout the world. And in 2018, polio cases fell so rapidly that there were only 33 cases in just 2 countries. And right now, we still just have 2 countries endemic for poliovirus, Afghanistan and Pakistan. In 1988, the Global Polio Eradication Initiative was established, and At that time, there were about 350,000 paralytic cases every year across 125 countries. In 2015, type 2 poliovirus was eradicated, and that was followed by type 3 eradication in 2019. We did have the vaccination switch. So oral polio vaccine, which used to contain all 3 serotypes, was switched out in 2016 for what we call bivalent oral polio vaccine that only contains types 1 and 3 because of the type 2 eradication. Unfortunately, that switch did not occur at a time when environmental poliovirus was eliminated, poliovirus type 2 was eliminated worldwide. And so we have seen a resurgence of poliovirus type 2 vaccine-derived cases and outbreaks happening in many countries worldwide now. So that brings us to 2022 and July, and now I'm going to talk a little bit about our New York State case and subsequent investigation. So our case was an unimmunized, immunocompetent young adult with no history of travel during the exposure period who attended a large gathering about 8 days before symptom onset. The case patient did have onset of abdominal pain, constipation, which progressed to back and neck pain. And 3 days after those symptoms began, did develop lower extremity weakness that took the patient to the emergency room. In the emergency room, it was thought that the patient had Guillain-Barré syndrome, actually, but an MRI was done, and it showed those classic gray lesions in the spinal cord that are suggestive of a poliomyelitis. So as part of the workup, astute clinicians did collect a number of specimens, including stool, which is the gold standard for poliovirus diagnosis, a naso and oral pharyngeal swab, and CSF. And the 2 stool specimens collected on day 10 and 11 of symptom onset were positive for an enterovirus. All other specimens were negative, and that's not unusual to have a CSF that's negative even in people who are infected with enteroviruses. Subsequent analysis of that enterovirus positive PCR did determine this was a vaccine-derived poliovirus type 2, or what we call a VDPV2. This was confirmed by the CDC laboratory, and it was noted that there were 10 nucleotide changes in the region encoding VP1, which is one of the viral capsid proteins. And this indicates, because we can use poliovirus mutations as a bit of a molecular clock, about 1 year of replication in 1 or more persons since that initiating oral polio type 2 dose. So, lots of questions about why this happened now. Why is an illness that has been eliminated for a long time in the United States suddenly reemerging? We do know that the United States overall is highly vaccinated for polio, and most people are protected from paralysis as a result of vaccination. National 3-dose coverage with inactivated polio vaccine amongst children 19 to 35 months, which is a good barometer for us on vaccination, was almost 94% in 2021. And we know that 3 doses is about 99% effective in preventing paralysis. So again, overall, nationwide, we've got high coverage. But we do know that pockets of under-vaccination remain in this country, and there has been more vaccine hesitancy as the result of the COVID outbreak. It's really in these communities that we need to focus our resources. So the map on the right shows the Rockland County in New York State. This is the county where the case patient originated. And you can see overall that the vaccination coverage of 3 doses by 2 years overall is about 64%, but when you drill down into zip code level coverage, you get a wide range of coverage. And in the 2 zip codes marked in dark orange and red, you can see that vaccination rates fall below 40%, which certainly puts people at risk for the acquisition of poliovirus infection. So to better understand the size and the scope of the outbreak, CDC did collaborate with New York State and New York City to test wastewater specimens around the county where the case patient resided, as well as neighboring counties and in New York City, because we know there is a lot of travel back and forth between those communities in New York State and communities in New York City. So first, just a bit about how we went about testing for poliovirus. I'm sure most of you know about the National Wastewater Surveillance System, or NWSS. This was developed a few years ago for SARS-CoV-2 testing and monitoring throughout the United States, but it's been a really useful asset to us for polio wastewater testing. NWSS covers over 12,000 sites in 50 states, 2 territories, and 8 tribal communities, and it represents over 96,000 unique wastewater samples and about 1/3 of the United States population. And the map on the right, I don't know if I can make it interactive, just shows you all the different places across the United States that are currently involved in wastewater testing. I am sure that's not a surprise to most of you who are also involved in this. So our approach was to follow really the global guidance, which states that wastewater testing can help to understand the extent of a poliovirus outbreak around a defined case of paralytic polio and help direct response efforts to communities most at risk. So we leveraged NWSS for both retrospective specimens that had been stored for SARS-CoV-2 testing, and then we used those same sites moving forward for prospective testing as well. We tested samples from the sewer sheds around Rockland County, again, the case patient county of residence, and then surrounding counties in New York State, including Orange, Sullivan, and Nassau. I'll show you a map in just a minute. We did test in selected boroughs of New York City, and then we also did some wastewater testing in both Connecticut and New Jersey, around certain areas where there are communities that have traveled back and forth to New York State and New York City. So wastewater specimens collected retrospectively from April and prospectively through December of this year were positive for poliovirus type 2. We have collected so far about 2,000 specimens, and 94 of those specimens were positive for poliovirus type 2. Changes in the VP1 region of these wastewater specimens were shared with the genetic sequence of the case patient. And so really the overall interpretation is that there was ongoing transmission of poliovirus in this community. We also noted that viral genomic sequence comparisons from the Rockland County case and poliovirus isolates found in the wastewater revealed a close genetic linkage to polioviruses found in wastewater in both the UK and in Israel. As most of you probably know, we can't tell directionality, so who gave it to whom, who traveled to which place, but certainly global travel did contribute to the case of polio in New York State. And here is a map that just shows the counties in gray where wastewater testing occurred. And then you can see the sewer sheds outlined in blue where we found positive detections of poliovirus linked back to the case patient. So here, I don't know if you can see my cursor, but is Rockland County. And so these are the sewer sheds that tested positive in Rockland. But in addition, we found sewer sheds positive in Orange and Sullivan to the northwest. Also Nassau County down to the southeast, and then in Brooklyn and a small portion of Queens in New York City. Overall, the ongoing transmission of this vaccine-derived poliovirus, as well as connections to other countries, did label it what we call a circulating VDPV2, and that was reported to WHO in early September. So I'll mention that since the New York State outbreak, there has been great interest among both academics and public health practitioners to expand wastewater testing for polio to other areas of the country. But I do want to reiterate here that for countries such as the United States, who have eliminated polio and have good water and sanitation systems and overall high vaccination coverage, the Global Polio Eradication Initiative really encourages sustained high immunization coverage and robust surveillance for acute flaccid paralysis instead of wastewater testing. Routine wastewater testing for polio is really unlikely to improve the system sensitivity, and so it's generally not recommended for countries who have eliminated polio. We conduct acute flaccid paralysis surveillance through our acute flaccid myelitis surveillance system, which is active in 64 jurisdictions, and actually did pick up the case of polio virus in poliomyelitis in New York State. So, and as we've had additional conversations with jurisdictions, I'll make the point that it has been challenging to determine how to message testing for poliovirus in the absence of a case patient. GPI, or the Global Polio Eradication Initiative, really says that wastewater testing is useful around the detection of a case of poliomyelitis. It can determine the extent of circulation around a case like we did in New York State, and can also help us direct resources where communities are most at risk. So again, taking the New York State case as an example, we were able to target vaccination efforts appropriately to communities rather than trying to offer vaccine more widely to a very large population that would drain vaccine resources. And I guess in closing, I'll make the point that testing for polio is quite different than testing for pathogens that one would expect to find in wastewater. I think Alessandro did a really nice job talking about detections of RSV, of flu, of COVID, of SARS-CoV-2. We expect those viruses to be in wastewater. And so I think, again, public health response and messaging around that is a bit easier than testing for a virus that is supposed to be eliminated in the United States. So there are many aspects of wastewater testing for polio that are really critical to think about before starting to test. One is the scale up of the pan-polio PCR assay that we use as the first step in testing for poliovirus. Our lab has been in the process of getting that assay published and out for people who are interested, but there's also appropriate quality control that goes along with that. And I just want to make the point that if academic places or other folks are testing for poliovirus and do find a positive, all positive specimens do need to come to CDC for confirmation and sequencing. CDC is one of the few places and the only public health place in the country that can actually grow virus in culture and to be able to get enough for genetic whole genome sequencing. The other pieces around poliovirus wastewater testing are just responding to a detection should you find a poliovirus of concern in wastewater. So one is really sorting out what polioviruses are of concern in wastewater. Do we jump if we find a Sabin2 virus, for example, a virus that is known to be in the bivalent oral polio vaccine, for example, and we would imagine, since it's given in millions of doses worldwide, could be shed in the United States versus a circulating VDPV that obviously has paralytic and capabilities, and so we would need to mount a public health response. Alessandro, I noted that you mentioned, somebody asked the question about what public health responses have been taken to the detections of those respiratory viruses in wastewater. This would be a key component to finding poliovirus, and really the response to finding poliovirus in wastewater is vaccination. And so making sure that the health department is aware that testing is ongoing and has a response plan in place should poliovirus be found is really a critical component before moving forward. The other thing to note, and I think this is something that people don't really think about, is because poliovirus has been eliminated in the United States, there are containment requirements following the detection of a poliovirus. And these containment requirements might include reporting stored polio positive specimens and potentially infectious materials to the United States National Authority on Containment. This can also include clinical specimens that are tested in hospitals. So it's a bigger deal than just reporting wastewater positives. And then I think finally that concrete communications plan is really necessary. We want to be transparent with what we're doing in terms of wastewater testing, but at the same time, don't want to raise unnecessary alarm amongst the worried well, who might take resources away from people who would need vaccines. So this is my last slide. I just wanted to say in summary, high vaccination coverage nationally can mask these areas with low vaccination coverage that are at risk for poliovirus transmission. And it's important to get in there and determine what vaccine confidence strategies work. We know these take time to implement and build trust in these communities. So that's something that we have been working on since July when the first case was detected in New York. We do know that wastewater will continue to be a tool to identify communities that are at risk for poliovirus importation. And so we are continuing to test in New York State, as well as opening this up to a few other jurisdictions who have populations with travel back and forth to New York State in order to determine whether there's additional ramifications of this outbreak. And so with that, I will acknowledge there's a lot of people working on this and say thank you and very happy to take questions.
Thank you so much, Janell, for that really interesting and thoughtful presentation. I just want to remind everyone to put your questions in the Q&A and upvote questions. And also, if you had a previous question for Alessandro that didn't get answered in person, you can look in the answered questions. He typed out a bunch of answers. Okay, so as the moderator, I guess I'm going to take advantage of that. And I'm going to ask my question first, which is, it seems like for a really high consequence virus like polio, that we're really going to be worried about like false positives in wastewater and how to interpret a positive when we don't expect it, or maybe it's a false positive. And so I was wondering if you could share any information you might have about how testing for wastewater for polio might generate false positives or not, because your examples were like true positives, like, we detected it where we thought we would and the sequence matched what we thought. And so that's like a true positive. But can you give us some examples of like true negatives that you observe, like where you tested from sewer sheds where you didn't think you would detect it and you didn't, or false positives where you detected it, like in one of the samples where you're like, this is bizarre, like we shouldn't be detecting it here, or what other category of like where you didn't detect it where you thought you would have detected it. So do you have any examples of that to share? Because I think, for those of us who might be getting really excited about testing for polio, like sort of providing the evidence that there's too many false positives to like make sense of wastewater detection, that would deter a lot of people. Like if we really saw scientific evidence that this like doesn't work. So I know my question is a little complicated, but it's like, it sounds like you guys are really worried about false positives. And I thought if you can give some examples of other observations you had from your study other than the true positives, that might be helpful for us.
Yeah, Ali, it's a great question. I would say for the most part, we're more concerned about false negatives. We're still working on this assay. It's not a quantitative assay at this point. So unlike SARS-CoV-2, we're not following concentrations or trends. It's mostly a yes, it was detected, or no, it wasn't. we are drawing a lot from our global experiences, and I think we're also learning that it's really hard to find a needle in a haystack. So maybe just something about the assay. I think the assay is fairly sensitive and specific for poliovirus. So if you detect an enterovirus on the pan-polio PCR and move on to sequence that, and it sequences as poliovirus, we don't see many false positives. I think we believe when we see a detection and we are able to sequence it to determine in fact, that it is a poliovirus. We have had some specimens that have tested positive by the pan-polio PCR, but with such a high CT that we've not been able to sequence those specimens to confirm poliovirus, and so we leave those as indeterminate. But I think what we're more worried about is the false negatives, because we know in very large sewer sheds, the assay might reach a limit of detection below which we're not able to determine whether there's poliovirus circulation. We've said in most cases that a sewer shed of 100 to 300,000 people is probably the best size to detect poliovirus. Sewer sheds above 400,000, I think there's lots of concern around false negatives there. And as an example, we've been using, again, extracts that were developed for SARS-CoV-2 testing. New York City had a number of negatives, but when we did large volume extractions, so we actually did the extractions with an eye on poliovirus, we did find positives there. So, again, there's a lot to work out, I think, with this assay. Hopefully that answers a little bit of your question.
Yeah, thank you. I'm going to turn to the questions in the Q&A, and I'll start with the most upvoted question. So this one is from Rachel Poretsky.
Oh, yes, Rachel.
Yeah, in Illinois. She wants to know, is there evidence that knowledge of potential circulating poliovirus can increase vaccine uptake, or the opposite? Or are we just guessing based on current vaccine attitudes in the US and the lack of significant uptake in New York this summer? What are your thoughts on that?
Yeah, right. Is it a carrot or a stick? I think it's a great question. Initially when we detected the poliovirus in both the case and then wastewater, there was an increase in the number of vaccinations given for poliovirus, mostly in the younger age groups. It didn't change coverage overall that much in those communities. And so again, I think it does speak to a lot of the vaccine hesitancy that's happened in the United States since COVID. We know obviously that childhood vaccination rates overall decreased during COVID. I think they're starting to catch up now, but I think it's a great question. Would the detection of poliovirus in wastewater encourage people to go get vaccinated versus versus not? What I do worry about is that those people who are motivated to get vaccinated aren't those that actually need vaccination. Those might be the worried well, for example, who have a full series of polio vaccine but want an additional booster. And so certainly we are starting to think a little bit about those questions with the Advisory Committee on Immunization Practices. We've just started a polio working group to address some of those questions around adult vaccination and boosters. But yes, it's a good question. I think as we start to roll out wastewater testing in other jurisdictions, it will be interesting to see the response that we get from the public should there be a detection.
Thank you for that great answer. The next question that's been upvoted is from Michelle Ammerman from Michigan, and she wants to know how much variation was detected in the New York wastewater sequences. I don't know if you have that information on hand or not.
I don't have the phylogenetic tree that we have developed. Unfortunately, I think that's actually hopefully about to be submitted for publication, so that information should be available soon. We have certainly seen evolution of that virus over time. lots of puzzling pieces though, because one thing to note is that the original virus that was isolated from the case patient, we've never actually found that virus again in wastewater testing, that exact virus. We've found variations of that, obviously, and we've seen evidence of progressive evolution of the virus, so more and more mutations in that VP1 region. Initially we were seeing sort of Sabin-like viruses, so those with less than 6 nucleotide changes in VP1, and over time we have viruses now with many more than 4 to 6. So definitely evolution and transmission happening in that area that has been documented.
All right, thank you very much. We're out of time, so we're gonna end the webinar now. So thanks again to our 2 speakers, Alessandro and Janell, for spending their Friday mornings with us and giving great talks. Thank you very much.
Thanks, everyone.
Thank you.